Good afternoon, or good morning, or good evening. Hello from wherever you're joining us. My name is René Kastelein, and I'm from the Netherlands, and I will be moderating this symposium together with Dr. Doug Burton, who will take over for the second part of the symposium. And I'm very happy to welcome you to this first research grant outcome symposium. A symposium we organized to make sure that you are aware, if you are not already, of the significant efforts that the Scoliosis Research Society is undertaking to promote research by its members in the field of spinal deformity, both in adults as well as in the pediatric population. And I think this program reflects that effort very much. So this is going to be the first symposium of this sort and of this kind. And I hope you will enjoy all the presentations that will be given. We have selected 6 grant recipients of different grant types, and during the mid portion of this symposium, Dr. Lafarge will give a presentation on the different grant types and the amounts of money that are involved. But let me assure you that it is a significant effort. And we would like this symposium to be very interactive. You cannot walk up to the microphone like in normal symposia. For some people that may be an advantage because there might be some barrier to do that. But for this symposium, we would like to invite you to use the question and answer facility, the thing in your Zoom screen where you can see the Q&A. And we would like to urge you and to encourage you to pose your questions to the presenters. Some of the presentations will be finished, others may be more under construction, and the presenters may even benefit from your suggestions and from your interest in their studies. So please use that Q&A and please be actively involved in what we'll be presenting to you in this following almost 2 hours. So thank you very much for being present, and I think we should start with the first presentation, which is given by Dr. Luigi La Barbera, who has a PhD in biomechanical engineering on posterior spinal function fixation, and he's from Milan. So Dr. Barbera, please go ahead with your presentation on biomechanical in vitro comparison of pedicle subtraction, osteotomy, and anterior column release for severe sagittal imbalance. Please, the floor is yours.
Okay, thank you so much for your kind introduction. I hope you see my screen and hear my voice properly. Can you confirm that, please?
Yes, I can.
Okay, very good. Thank you so much. Okay, I would like to give you some information about this SRS new investigator grant, which was concluded in September 2017. The main topic is sagittal balance in adult spine deformities, which is a well-known and established issue. This kind of issue can be treated surgically using very invasive surgical techniques such as pedicle subtraction or osteotomy and anterior column release or realignment. PSO briefly consists in an open posterior approach, removing the posterior wedge resection and removing the posterior and middle column while keeping the anterior spine almost unaffected. While the osteotomy is closed, posterior fixation ensures the stability and should ensure also that adequate loading is going through the osteotomy to promote fusion. Anterior column release is a little bit different as a strategy because here we have to release the anterior longitudinal ligament, so we interrupt the continuity of the anterior spine. We can potentially perform a posterior osteotomy in order to achieve greater sagittal correction after the implantation of an hyperlordotic cage. The literature. The clinical literature already showed that PSO brings a lot of postoperative complication, mainly related with rod fracture and malunion, up to 40 to 30%, while for ACR, intraoperative complications are rather lower, but postoperative complications are still unknown, since this is a more recent technique and evidence is still limited. We wanted to answer this question: how many rods are useful to provide primary stability and rod fracture following PSO, and are adjacent in the body cages really beneficial? Regarding ACR, we wanted to answer these two questions. Does bilateral fixation provide primary stability and avoid rod fracture? And how does ACR fixation compare with PSO fixation? In order to answer these questions, we performed an in vitro study where we selected 7 human cadaveric specimens. We prepared all of them according to several preparation stages. We performed a PSO at L4. We tested this configuration as a 2-rod, 3-rod, and 4-rod technique. After that, we implanted also adjacent cages, and we tested also, we repeated the test on these 3 scenarios. After that, we performed an ACR at L1, L2. We tested this configuration as a standalone technique, and following that, we added 2 bilateral rods. We performed the in vitro test on a well-established spine tester, where we were interested in the local range of motion as a measure of primary stability and possibly fusion, and the primary rod strain using a specific strain sensor, and this strain are a measure of rod fracture. The range of motion demonstrates that all PSO constructs have a comparable effect in reducing the range of motion, with significant effect only after cages implantation with 3 and 4 rods in flexion extension and in axial rotation, which is consistent with the literature known from the past with higher risk of malunion without cages. Moreover, ACR as a standalone technique is a very unstable scenario. Following a simple 2-rod fixation, we can significantly reduce the range of motion, but this scenario is comparable or somehow worse in flexion extension to other PSO constructs which are known to be at high risk of malunion. Regarding the maximum rods strains, we found that supplementary accessory rods significantly reduce primary rod strain without cages, confirming the higher rod fracture risk found by the International Spine Study Group with fewer rods. We found that supplementary accessory rod coupled with cages most effectively reduce primary rod strain, which confirms the result from Gupta and colleagues. Moreover, regarding ACR, we found that bilateral fixation is comparable in flexion extension and axial rotation with 2 and 3 rod PSO construct, which are anyway at higher risk of rod fracture. But we still don't have enough information about this configuration from the clinical literature. Therefore, we can conclude our study saying that regarding PSO, supplementary accessory rod plus interbody cages are recommended to provide primary stability and minimize rod strain. Although a supplementary accessory rod without cages and a central satellite rod plus cages may offer some relative advantage over bilateral fixation. Following ACR, we found that bilateral fixation provides primary stability and rod strain equivalent or a little bit worse compared to PSO construct without cages. Therefore, using additional accessory rods is to be absolutely recommended. After the conclusion of our study, to give you some more hints about the ongoing debate, we found one only paper, a retrospective study from Godzik and colleague, reporting a rather low 4% of rod fracture rate following ACR, but they found that there is no additional benefit in using additional rods. But otherwise, anyway, the same group of authors also performed an in vitro study where they also tested the opportunity to use supplementary rods, and they found that this configuration can promote fusion and avoid malunion, which is something really established from the past literature regarding ACR and PSO fixation with additional rods and supplementary rods. To conclude, we want also to report here a more recent result of our study, where we used an innovative digital image correlation technique in order to evaluate the strength of the vertebral spine. And we found that following PSO, a 4-rod technique with adjacent cages can be really beneficial in order to promote the load sharing of the anterior spine and promoting fusion, which is something reported in the clinical literature. With that, I would like to acknowledge all my authors who were a wonderful team, and acknowledge the SRS for supporting our study. Thank you.
Thank you very much, Luigi. So maybe people can hear me now.
Yes.
You can, great. So very nice presentation. And for the audience, the purpose of this symposium is to have plenty time for discussion. And I see there's one question in the Q&A, but I'll take the moderator's prerogative and start the discussion with you, if I may. And you know, PSO, in my mind, it's a fun procedure for the surgeon. It shows spectacular results on the X-ray, but it's a very unphysiologic situation where you have a totally isolated, collapsed vertebral body without posterior structures and no bone bed for the fusion. So I think one of your conclusion is that you need a lot of rods, but it's not a substitute for biologic fusion. This is just a general remark, and I think we're in an era where we start using more and more heavy metal. And 4 rods is becoming usual for PSO and osteotomy surgery, but that's not how we ultimately should solve the problem, I think. And
I totally agree. Yeah.
Your anterior option, but can you comment on the idea of more rods rather than trying to get biologic fusion?
Okay. Yeah, absolutely. PSO is a very, very, very invasive technique, which involves a lot of blood loss, many complications, and many consequences on the patient. Using more rods and adjacent cages can be a technique to prevent rod breakage and reintervention, and at the same time promoting also fusion and achieving good results in these terms. However, ACR, as we investigated, is a more recent technique which would provide a less invasive approach, a little bit less heavy for the patient with a lower complication rate. But anyway, we can say that based on our results and from the literature published so far, using additional rods may be anyway necessary also with this minimal invasive technique. Therefore, maybe the clinical literature already reported that there are some other tricks that the surgeon could use, maybe using some angulated surgery bed in order to gain some advantage and again some correction just with posterior fixation without requiring such an aggressive technique.
Thank you. I would like to pose one more question before we go to the Q&A, because I didn't understand in the anterior setup, you have a vertebral body cage with screws, I believe. It's fixed.
Yes, yeah, lateral screws, yeah.
But then it basically spans only one segment, right? Only
yes, one segment, yes, exactly,
above,
yeah.
Cage vertebrae below. And when you compare that to the stability of the cage with an additional rod system, it seems to me that you bridge like maybe 4 segments from what I see on your picture. So how fair is it to compare your standalone cage as far as flexibility is concerned to the rod construct where you have many more segments fixed?
Yeah, good questions. We performed this standalone technique and we tested this technique as a standalone approach just to see how much stability could these lateral screws provide, which is something that also Godzik and colleague recently investigated. We found that this is not enough. And of course, PSO would distribute the correction over, let's say, 1.5 spinal level, because we are resetting one portion and that portion cannot be accounted as one spinal level, full level. Regarding ACR, we are forcing all the correction to be really focused on just one intervertebral disc. And probably in that condition, we have to bend much more the spinal rod in just at the level where the intervertebral disc and the cage is located. So maybe ACR can be more aggressive in terms of rod contouring than PSO.
Okay, let's leave it at that because I'd like to discuss much more on this topic, but there's more questions. Doug, shall I just go ahead and go from the top?
Yeah, I think so. Let's do it that way.
So Dr. Lee reports, very interesting result. Do you have any plans to compare fusion rates in vivo between the two constructs?
To be honest, not at this time. I'm an engineer working in a technical university, so I'm looking forward to keep on researching on the clinical side with adequate collaborators. At the moment, we are not planning that.
So there's many questions, and maybe I've taken too much time even. I'm sorry for that, but this is interesting enough to discuss. All your questions will be answered. If not now, at a later stage, they will be answered. Doctor,
Okay.
so let's just go on until time is up. We have about 5 more minutes. So where possible, please a short answer to the question. Dr. Eastlack, where posterior release is performed for the ACR specimens, given that common clinical practice before testing? This is how I read it. I'm not sure.
I think he's asking, did you do a posterior release on the ACRs? I think you did, didn't you? It looked like
we did it. Yes, yeah, we did it.
Okay. Yeah. Okay, so that question is answered with yes.
Yeah.
Then Professor de Kleuver, also from Holland, when performing a PSO with cages, where and how did you place the cages in anterior or posterior approaches?
These cages were meant to be implanted laterally from an X-leaf approach, so transpsoas approach.
Yeah, I think I read that also. Yeah, so that's answered also. Dr. Rahan, what about the success rate in practices? So the success rate, so that's in clinical practice, I assume, and I think this is not a clinical study, so I'm sorry, but I think I'll skip this question, and maybe it can be posed.
Hey, Renee, let me interject here real quick. Luigi, the Professor de Kleuver's question was about when you were doing the PSO. And so when you do the PSO, obviously we're doing it from a posterior approach. So did the cage that you put in your PSO specimens, were you placing that from the back, or were you, I mean, it's easy because it's all, it's articulated. You could go from whatever direction you want in the lab. How did you place the cage? From the back, or did you go around to the side?
We went to the side, but for us was much easier because we don't have all the body. We just have the spine segment.
Do you think that really fairly represents what a surgeon could do in the operating room? I mean, we can't go from the side if we've got them exposed from the back. I mean, we could do it as a separate stage, but it's this pretty small hole that we've got there to put a cage into. Do you think the cages you were placing really represented what we could do in the clinical setting?
For the preparation of this specimen, Dr. Marco Braida Bruno and Dr. Andrea Luca were involved in this preparation. So we let them to freely adjust the implantation of the cage according to their surgical routine. So was kind of realistic and close to the surgical practice because 2 experienced surgeons did it. At the same time, of course, in vitro is much easier because there is plenty of space to assess also anteriorly or laterally the cadaveric spine, because we don't have muscles, we don't have all the surrounding structures and vessels also. Gotcha. So I think it's kind of representative to represent the passive behavior of the spine segment. Of course, we didn't account for muscle forces, gravity loads, which is something which can be addressed with a more complex kind of experimental technique. Here we are doing with a comparative analysis using pure moments, which are kind of meant to improve comparability rather than represent really in vivo actual loads for each specimen, each patient.
Thank you.
Okay.
Do we have time for one more, Renee?
Pardon?
We have time for maybe one more.
Yes, I think so. I see one here from Dr. Mehta. So he says, okay, you need to address any aspect of the foraminal compromise with additional posterior decompression in the ACR group. Yeah. So what he's saying, I think, is that if you do an anterior cage, you may need to do a decompression unless you have an indirect decompression, of course. But if you would have to go from the back, you would then stabilize or destabilize that area, but it would also give you the opportunity to put in screws and put a rod. Maybe that is my answer to Dr. Mehta. And he has another one, and I'll let you answer that. And then we go to the next presentation. With the PSO, we sometimes need to place additional cages at the levels on either side. How do you approach that aspect with ACR? Do you consider adding more cages with the primary ACR?
I'm assuming the levels above and below.
Yeah.
I know. I saw it.
Yeah.
I saw such a technique to implant adjacent cages also above and below the ACR in surgical practice. But to be honest, I like to go to. I would rather plan a new experiment in order to really be aware of what I'm answering. At the moment, I don't have such an answer. Maybe using finite element models can be a good option in order to try going in that direction and answering these questions. At the moment, I cannot. I'm sorry.
I think we have to finish this discussion. It's very interesting, and I think you did very well as a basic scientist in the field of very many clinically related questions. So compliments.
Thank you so much.
And thank you very
to be
much
here.
for your presentation. And the questions that are still out there will be answered at a later stage. So I think it's time to move on to the next presentation, which is by Professor Negrini, who is also from Milan. The title of the presentation is Prediction of Curve Progression in Idiopathic Scoliosis Without Treatment. And this program received the standard grant. I think Professor Negrini has around 600 publications, and he's well known in the field of scoliosis treatment. So Stefano, the floor is yours.
Thank you very much, René, and thank you for the honor. And in fact, this is the first time for the SRS grant presentations, and 2 Italians are starting. That's great for our country. These are my disclosures, and with this slide, I would like to thank the SRS for the honor of receiving this grant and the major researchers of this research grant. So the question here is natural history of AIS, that is highly important in conservative treatment because we need to know it to check results, to correctly plan the treatment, and to adequately inform patients and parents. We performed a meta-analysis, and it was quite clear that we don't know well the natural history. Many of the studies included treated patients or different kind of patients. And one of the results of the last study, of the BRACE study, was that first, we will not be able to study anymore the natural history because we will have to brace patients. And second, the natural history is much worse than what we expected. And we found a progression rate that was really huge in curves between research 02 and 2040 degrees. So the aims of our study was to try to solve this problem, how to have data about natural history nowadays. And we thought to look back. So we thought to check all the radiographs prior to the first visit in our clinic. And we have a huge database for which we had a lot of data like that. And so we started with the last data collection was in January 2020. We included in our database, there were almost 23,000 patients, and we selected 7,400 almost with more than 22,000 X-rays. And it was a huge quality check that we had to do. And we evaluated more than 2,400 patients individually during the consultations. And we collected some 6,000 more X-rays. We did double-blind measuring. And all these people have been involved in this activity. And we ended up with 2,300 patients and 5,600 individual radiographs that we could introduce in our model. And here you can have a rapid look at 118 participants, and you can clearly see how the behavior are very, very different, as we know from clinics, for all the different patients. So the first thing we tried to do was to develop an overall model, but the overall model for all growth age was failed because we had only 55% of prediction within 5 degrees. And for this reason, we looked at this old hypothesis coming from the Duvalbo pair that described the scoliosis progression compared to the spinal growth. And from that old study was quite clear the importance of puberty, and we all know in clinics how important it is. And there are 3 different stages that have been identified. The first up to puberty, the second one up to RISER 1 or 2, and the third one until the end of growth. So we try to identify from our huge database the point P, the point of start of puberty, but that was not really possible because of the height measurement error and the spread in time of the point P. So this also didn't work. And so we tried to develop something else, and we still remain on the same hypothesis to divide in 3 different areas. The first up to age, let's say 10, as we used to say for idiopathic scoliosis. A second one, group B, with 2 observations into the area between age 10 and RISER 1 or 2. And the third one that was after RISER 1 till the end of growth. But dividing all our patients, we had these 3 groups, but we also had 3 other groups that included the overlap between these areas, when one observation was in one area and the other observation was in the other area. So we focused only the pure groups, A, B, and C. And the first thing was to identify if 10 years of age, as we used to think of adolescent idiopathic scoliosis, was quite correct in terms of age, but we expanded a little bit up to including all age 10 into our A group, because as you can see, there were very, very few mature patients at that stage, while up to age 11, mature patients increased much more. And so in our group A, we ended with 340 observation, and we have been able to do a 4 rounds validation, and we had a model that was the first we developed with a 74% prediction within the area of plus minus 9 degrees. And in group B, with almost 1,000 observation, with a much better validation, 10 rounds validation. Again, between plus minus 9 degrees, we had a 69% prediction rate. Then we realized that probably we could do something better, and we moved to another way of predicting, and this has been applied until now only in group C. We are still working with this project is not yet finished. And at this point, with this kind of model, we had an 86% prediction within a range that is variable, that goes from plus minus 5 when we are close to the starting point to more or less plus minus 10 when we are far from the prediction point. And if we include the 5-degree classical measurement error that we know, we go up to 98% prediction rate. So we expect now to be able to apply this same model to the group A and B. And this is the overall model that comes from the superposition of this free group that we have seen till now, and it is quite coherent with what was the model of Duvalbo pair. But at this point, we have the numbers to be able really to predict something better. And our next stages will be obviously finishing the analysis, developing a better combined model, and then we will use the group DEF, the group that we've overlap among the different groups, to try to check clinically if these patterns follow what we are finding. And also we will look not anymore only at the couple of measures, but also at the number of patients. We have almost 30% of patients that had more than 2 observations before coming to our first consultation, and this will serve for a clinical validation. This is it. Thank you.
Thank you very much, Stefano. Thanks a lot. This is a lot of data, a lot of information, and I want to compliment you with gathering all this and presenting it to us in this form. So, are there questions? Q&A is not really filled yet, I think, so I'll go ahead. Would it be right to say that the natural history of a scoliosis depends on the curve magnitude at the onset of puberty? I think that's more or less what you indicated.
Yeah. Okay. The aim of our study was really to try to figure out the trajectories of patients, because when you speak to patients, we had something that we did in the last year similar to this, but not so accurate. When you speak to patients, they want to know what would have happened to them without treatment. And that is really crucial for them, because sometimes they made a lot of sacrifices, but they don't see big results. And they think, okay, I did everything, but I remain stable, but they don't see what the natural history would have been. So that is a very good way to communicate to patients. And the second thing, as you have seen from the overall model, you still have progression also after research 2-3. That is not what we used to think. We used to think that at that point is finished, but it's not true. There is a very slow progression also until the end of growth. And you have quite some progression also in the juveniles, while as you said, the worst period is for sure just before puberty. And so the models give us a better understanding.
So the question to me is, when does the spine become subject to developing scoliosis? And in my mind, that would be at the time, and this is more or less the way we are looking at it at the moment here in Utrecht. Does it happen at the moment that the weight on the spine and the loads on the spine increase rapidly, which we could call puberty, but not hormonal puberty, but just puberty in the sense of mass and kilograms or whatever, and the maturation of the spine, of the disc, of the structures that stabilize the spine is not at that stage yet. So for me, one problem is, when does the risky period start? That's probably, like you say, when puberty starts. But what is the time that puberty starts? That's one question. The other question is, when does the spine become stable? And I think it becomes stable much later than we've been inclined to think. Like you say, RISR 2 or 3, not at all stable yet, probably not RISR 4 or 5. Probably the spine is still developing after RISR 5. I think we can safely say that also. Do you agree?
Yeah, I quite agree. I think that there are differences. I used to think myself as there is a phase for etiology and there is a phase for pathogenesis. The etiology is what we don't know, but the pathogenesis we know quite well, and that depends a lot on the curvature. So as you said, when you overcome a certain curvature, even in the adulthood, you are not stable. It tends to progress very slowly, but it progresses. But below a certain threshold is not that important. I think the same applies also during growth, with the problem that in puberty you have a sudden growth and all the musculoskeletal control just doesn't work anymore well, and the patients start walking in strange ways, and the same, they are buckling, and that's the same for the spine, and that is the worst period. This is my thinking, at least.
Thank you. I agree very much. So when I started my first question, there was no Q&A yet, but now there's about 10. So I will go to, and once again, the other questions will be answered. I will go to Dr. Parent. Great work, Professor Negrini. Did you have only RISR sign to determine skeletal maturity? Do you think it would be better with Sandler's hand score?
Unfortunately, the research was based on the X-ray that the patients had before coming to us. And for that reason, it was not possible to have anything else than the X-ray and the age. And we are working on those data only, unfortunately.
Okay. Have you done any assessment for mature scoliosis progression from Dr. Raihan?
There is another study that has been done by Sabrina Donzelli that is co-author with me of this paper and will be presented possibly at the SRS if it will be accepted. And there is this study exactly on that, on adulthood and the rate of progression in adulthood with this almost the same methods.
Okay, that looks very promising. Another question on 3D by Dr. Gomez. Why we are still using COP angles? Will you consider overall 3D alignment?
This is a great question. At this moment in time, as I told you, we had to rely only on the frontal X-ray, but we want to rerun the same study, also including all the patients with the sagittal X-ray as well, but that will reduce a lot the number. One of my dreams would be that the SRS could start an effort to collect this data from all our patients all over the world and perform something similar with much more numbers, and that will probably give us really the natural history. But that is something that we have to discuss among us.
Okay, thank you very much. Doug, you have any further questions you would like to?
Yeah, I guess, and I think you mentioned this, but is this ready for clinical use, or are you now ready to prove that it's applicable in clinical use before you release it to the masses?
Yeah, I would say that the validation process we have run is quite good, quite reliable. So we will for sure start using it in our clinical practice, verifying, and so probably that will be another study that will come afterwards, verifying what really happens. From our database, again, we have a lot of data there. From a clinical point of view, we use something very similar, and is in any case is highly useful. And it was much more rough, much more wider. Now we are closing a little bit more the range of identification, and that will be even more useful for patients.
Thank you very much. Thank
Yep.
you. Happy, Doug? Yeah. I think
Yeah.
This was the answer you wanted. So thank you very much, Professor Negrini, for your presentation. I would like to move on to the next presenter, which
Thank you.
Thank you very much. So the next presentation is by Dr. Rotenflew from Oxford, together with Dr. Lafarge, who will be speaking right after him. The title of the presentation is The Spinal Balance Score, a novel linear and unidimensional patient-reported outcome measure for adult spinal deformity. They received the standard grant for this research. Dr. Rotenflew is very active in Eurospine education. He has kept me busy for quite some time in getting an update on some lectures. So now it's up to you, Dominique. The floor is yours.
Yeah, thank you very much, Rene. And I would like to take this opportunity also to thank SRS and the Research Grant Committee for funding this project, and also for inviting us to present here. As you've already mentioned, this project is a collaboration between ourselves in Oxford and Virginie Lafarge's group at Hospital for Special Surgery in New York. So the motivation for this project was really, I at some point wanted to design a randomized controlled trial for adult spinal deformity. And when it came to the question of a primary outcome score, we really found that there was not really a disease-specific score that potentially can be used as a primary outcome measure, although we now know that there have been trials using other scores. So the most commonly scores used are the Oswestry Disability Index and the SRS 22 score in more than 80% of the publications here in a systematic review from 2015. They used these two scores. They cannot necessarily be considered disease specific and have actually never been formally validated in that specific patient population. More recently, people have embarked on using PROMIS, really due to a lack of a better instrument. They, again, cannot necessarily be considered disease-specific. They have some somewhat different psychometric properties, the PROMIS, as opposed to the ODI and the SRS 22, which don't really meet the modern psychometric requirements for linearity and unidimensionality, meaning essentially linearity means that, if we have a double the score, then in a linear score that should more or less match to twice the disability, which is certainly not the case in general scores that use ordinal outcome scales. So the project essentially is in 3 stages in order to come up with a novel outcome score. The first stage is by far the more laborious one, and that's essentially why we're still stuck at that. That's when we essentially identify what we actually need to measure, what type of questions we need to ask patients, and derive then the items that need to be incorporated in the score from those responses. And that's exactly what I'll present here. The next step is then to have a preliminary questionnaire and reduce the items according to the psychometric properties, and then validate the questionnaire, which validate the final questionnaire. So this work here is really on the first part, what do we actually need to measure? Those are the presenting symptoms, limitations, and expectations in adult spinal deformity, which really was a patient perspective, because we conducted 100 patient interviews face-to-face. 50 were done in Oxford and 50 in New York, and then matched the responses based on the protocols to the ICF domains, which is the WHO International Classification of Functioning and Health Framework. Those domains were then ranked according to their frequency, and we included a very broad range of patients here for deformity, essentially the same criteria that the ISSG and the ESSG use, to really capture a broad range of the pathology, that we get a broad range of replies or responses. We were mostly interested in, and those were really open-ended questions, what symptoms that patients were experiencing in relation to their spinal deformity, what limitations they had in everyday life. If they were to have any treatment, what would their expectations for treatment be? And if they already had surgery, we wanted to know what improved and what did not improve. And as a sort of general score, a measure, we had the EQ5, the EuroQoL, EQ5D, the EuroQoL score in there. So out of the 100 patients, 88 were female, probably not very surprising. Then about half of the patients had the diagnosis in adulthood, 40 patients AS, and only 4 cases had a diagnosis of scoliosis at the age less than 10 years. So those were all adults. Half of them roughly had surgery before, and the other half have not had any treatments before. What we found in our replies is that we had 41 unique ICF domains. In symptoms, though, those were 220 items with 21 unique domains limitations. There was a much wider spread with 350 items and 33 unique, and expectations, 27 unique items. Not surprisingly, in the EQ5D, according to the EQ5D crosswalk index, patients who never had surgery before demonstrated more disability than patients who already had surgery before. So those are, this is an overview of the ICF domains here for symptoms, and they represent just over 75% of the total responses. So patients, their main concern, and really 99% of all replies, was the sensation of pain, then maintaining a body position, sensation of stiffness, that could also be muscle stiffness, walking and general mobility, as well as touch function, and here that specifically was relating to numbness. Limitations, they were much broader. The top items here were really walking or general mobility, doing housework and maintaining a standing and a sitting position, as well as lifting and carrying objects. And with the expectations, that's quite similar to the symptoms, was that they would like to have a pain improvement, be able to carry out their daily routine, maintain a body position, and have their general mobility improved, as well as walking distance. We also compare patients who did have surgery as opposed to patients who did not have surgery, to see whether we already observed there a certain response shift. That was not the case. We had 4 items overlapping. What was also important is that we looked at what really improved in patients who already had surgery as opposed to what did not improve. For example, the top domain there, and in patients who did not have surgery, or what in patients who did have surgery but what did not improve, was the item B77,800, which essentially stiffness. Now, in most of these cases, we do a long fusion, so stiffness is never going to improve after surgery. That, if anything, is getting worse. So, this would not necessarily be an item that would make sense to include in an outcome measure, because certainly from pre to post-operative, we would not observe any change there. Most importantly, we compared the items, and in the table on the right, you really see the summary of. We came up with 10 items that were really the top items out of these 3 large domains, and when we compare it to the Oswestry Disability Index, we only have overlap with really 4 symptoms, or 4 items: pain intensity, lifting, walking, as well as standing. It gets much worse if we compare it to the SRS 22. There's actually only 3 items and 2 pain questions that overlap with the responses that we got from patients from the interviews. So to conclude from this, we can say that actually the Oswestry Disability Index and the SRS-22 do not really seem to probe pain and disability adequately in patients with adult spinal deformity. And, you know, if we focus on these domains, we should be able to design a patient-specific outcome instrument in order to then come up with a novel score. So I've already gone into these steps. We had one in the quote unquote complication when we tried to find what is the best methodology now to derive items from our responses to then populate a preliminary questionnaire. I was by one of the senior researchers at the Department of Population Health in Oxford. I was advised that actually the way we went about with it would not be accepted by the FDA. Well, while it was a good first step to actually interview patients, have a written transcript, we need to have a recorded transcript and then derive the questions from there, and only then the FDA would accept outcome studies, for example, for to get FDA approval. Now, since many of the majority of the study groups are, at least to some part, funded by industry, using an outcome instrument that is actually then not recognized by the FDA, because it is not really guaranteed that what we're measuring is what the patient's main concerns are, that would not necessarily be worthwhile. So we decided to really go back and redo parts of the study, and we have to interview about 30 patients, then with a recorded transcript from where we then can derive the items to populate a preliminary questionnaire then for item reduction. The SRS Research Grants Committee has generously granted us a no-cost extension for another 2 years, as we're expecting that. Still, due to COVID last year, we couldn't do any patient-facing research, and hopefully this year this will be better. So our timeline is really to, by the end of 2022, to have a validated score. So I'd like to acknowledge all the researchers and collaborators, especially at the Hospital for Special Surgery and in our unit, as well as the COSCO project, which was led by Marinus de Clover and his collaborator Miranda van Hoff, who gave us a valuable input, especially in the initial stages. Matching it to the ICF domains was essentially their idea. Thank you very much, and I'll be open for questions now.
Thank you, Dominique. So we are, as is often the case during a symposium, but also we are going over time a little bit maybe by now, but we'll start with the questions that I have here in the Q&A. Dr. Mehta, how do you deal with changing perceptions and lack of realistic expectation of patients based on general health and frailty? Can that be captured with this tool?
Well, I mean, that, those are very different concepts. What we try to do is, what's really important to be able to then measure outcome is to have a unidimensional score. So actually, those type of concepts, that they may not necessarily point in the same direction and actually confound the score. And generally, if you use a procedure such as latent trait analysis or rush analysis, which we're going to use, those items would then be filtered out that if they're not actually on the same scale. So I think that's why it is important, if we look into the COSCO project, for example, that looked into, defining a core outcome set according to the value-based healthcare tiers, which are 3 tiers that we, in the long run, really look at outcomes in a multi-dimensional fashion, not necessarily as a single outcome score. Unfortunately, this is still what we need if we design a randomized control trial.
Thank you. One more from Professor Parent from Edmonton, Canada. The diagnosis of adult spinal deformity has both sagittal and frontal components. Does your system allow for assessing both conditions, both the sagittal and the coronal plane?
Yeah, that's a very good question, because well, we use very broad inclusion criteria, what the study groups use. So both patients with coronal and sagittal deformities are in there. And that's actually paramount if we want to be able to put them onto the same scale. And, you know, if an outcome measure is unidimensional and is linear, then those different diseases are then essentially on the same scale, and we can directly compare the disability and pain according to that score between those two patient groups. That is always provided that they do not exhibit any differential item functioning, which is something that we need to test. So we need to test whether each item actually responds differently, or whether different diagnostic groups respond differently to a specific item. You know, some patients may prioritize one over the other. If that's the case, then it either has to be excluded, or we have to accept that we cannot directly compare these two patient groups with the same score again. Our ideal would really be to have a unidimensional scale, that essentially one linear scale where those patients are essentially on the same scale, such that it would allow for direct comparison.
Okay. Thank you very much, Dominique. So that concludes the first half of this symposium. And I would like to hand over to my co-moderator, Dr. Burton. Doug.
Thank you so much, Renee, and thank you to all the presenters for the first session. That was great. I'd like to introduce now Dr. Virginie Lafage. Dr. Lafage is a researcher at the Hospital for Special Surgery in New York, and she is the chair of the SRS Grant Outcomes Committee, and she's going to speak to us a little bit about what the different grants are possible to receive and the details about that. Virginie?
Thank you very much. So I'm going to talk about the different grants that you can all apply to and what is the process. And all this information basically is also available on the website. So something to keep in mind is that we have like two big categories. One category just involves one-step application. Those are smaller grants for resident and fellow or micro grant. And our largest grant require like a two-step process. So first, you're going to have to submit a letter of intent, and if selected, you will be called for a full submission. So let's start by the one-step grant. So what is common to those two types of grants is that one of your co-PI need to be a SRS member, but you don't have yourself to be an SRS member. Funds are for work to be performed or in progress. And the application is very straightforward, like 300 words. And you really have to highlight like what is the impact of your grant on the SRS mission, your career, your specialty, and what will be your primary outcome of success. So if you opt to apply for a resident or fellow grant, like really like this is meant like to promote a young researcher and put them like in a career of being like a full-time researcher in addition to their clinical practice. So this is open to all residents and all fellow. Preliminary data is not required. The duration is up to 1 year for funding up to 10,000. Last year, we funded like 2 resident fellow grants. The second category is what we call exploratory micro grant. So this really aims like to promote the diversity among the SRS membership. This is open to all SRS members. The duration is up to 1 year, and the funding is up to $2,500. So you may ask yourself, okay, what does it mean, those micro grants? And that's really like where you can get creative and think a little bit out of the box. So let's say like you want to travel to visit another clinical center that would be appropriate for this type of grant. You want to support a resident or a student, either for research or for traveling on a medical mission. You don't have a lot of experience and you want to start like by a smaller grant, that would be appropriate. And you can also use this money like for educational research, advocacy, safety improvement. Just think about something that relates to deformity, of course, but that doesn't necessarily fall into a standard grant. So then like for the full application or bigger grant, we have like 4 categories. New investigator, standard research grant, the Biedermann Innovation, and the SRS Cottrell Basic Science. So what is common to those 4 grants is that you need at least to have 1 SRS member as a co-PI. There is something specific about the Biedermann innovation is that it's only open to a young researcher. By young, I mean like 45-year-old or younger. And the timeline is a little bit different than for the smaller grant. So by March 15, the letter of intent are due. By April 15, if your letter is being selected, you will be invited to submit a full application. And the full application will be due in May 15. So for the letter of intent, it's a 2-page document, no figure, no table, just simple word, max 750 word. And really, like, you need to pay extremely attention to the introduction, because that's where you're going to sell your project. So the introduction should take into account like the team, the problem, the significance, the innovation if you apply for the Biedermann grant, the unmet need, and the hypothesis. Of course, you will add some information about your method, your previous work, budget, and feasibility. And in terms of grading criteria, the most important criteria is how does the study address an important problem for the SRS? That's really what we're looking for, because we are trying to stay away from grants that are extremely well written with a fantastic team, but that have nothing to do with deformity. So it's a really important criteria. Second criteria will be like, well, is it feasible, you know, and what is the budget, what is the team, and all the standard criteria. If you're invited to submit a full application, you are allowed to submit like up to 10 pages, where you're going to describe your specific aim, significance, method, supporting data, and budget. And you will be graded according to 4 different criteria: the impact of your research, the innovation aspect, the approach and method, and then the investigator, associated team, the environment, your collaboration. So what are the different categories? So new investigator, as the name mentioned, is like for a young member. So young member is being defined as less than 10 years of practice and without any history of previous grant in terms of SRS standard grant, ORS, ORAF, or federal. We really want, if you apply for a new investigator, we need you to be involved in the grant. So don't take the idea of one of your senior member and just put your name. This is for work to be performed, not for work in progress. The duration is up to 2 years with up to 30,000 funding. Last year, we funded like 3 grants. A standard research grant is like for a more experienced researcher. And we would like those applications to basically be the foundation for larger grant or larger project. If you have an ongoing standard research grant, you're not eligible for this category. Again, funds are for work to be performed, and now the funding is up to 75,000 over a 2-year period. 3 grants were funded in 2020. Now let's talk about the Biedermann innovation. This is a new type of grant that is really designed to support innovative research by young clinical investigator. Again, young clinical investigator being defined as 45-year-old or younger. Funds are for work to be performed, not in progress. And really, like, you need to focus about the innovation. How does this project will push the innovation in the setting of spinal deformity? There is no requirement in terms of the duration of research. We all know that innovation can take some time. And the funding is up to 50,000. Finally, the last category is about like the SRS cultural grant. So this grant should be like specific to pediatric scoliosis. And the type of project that are eligible are anything involving like molecular, cellular mechanism, medical imaging, but also some biomechanics, as long as they focus on pediatric scoliosis. You need, as an SRS member, you need to be involved in the project, and the full application will be reviewed both by the SRS Grant Committee and by the Cottrell Foundation. The duration is up to 2 years with the funding up to $50,000. So just in conclusion, very quickly, like over the past few years, since 2012, the SRS has awarded 75 grants for a total funding of more than 2 million. Those grants were awarded in 9 countries over 3 continents. We had 122 presentations, several nominees, either in the Ipsos Society, and like so far about like 70 publications and 70 more to come. When submitting a grant, always like go back to the foundation of the SRS. Keep in mind what is the SRS mission statement, what is the SRS research mission, and what is the SRS research vision. If there is any question, I'd be happy like to address them, and I hope that this was informative.
Great, thank you so much, Virginie. If you have questions, you can put them in the Q&A, and Virginie will be able to answer those online for you. Also, I think that the link to the SRS grant website was sent out in the either in the chat, I think in the chat, so you guys can access that as well. I want to thank Virginie. That was excellent, very informative and detailed. We're going to move on to the second half of our program, and we're going to start with Dr. Jim Sanders at University of North Carolina at Chapel Hill, and he's going to talk to us about growth of the spine in children, a longitudinal prospective investigation. Jim? And yep.
Thank you, Doug. Can you hear me now?
Yeah, great.
Okay, so thank you. So I'm going to be speaking to you about this, and I'm going to be one of your examples of failure today. And this is a tale of some headwinds. And first of all, I want to express my gratitude to the Scoliosis Research Society. I received an SRS grant early in my career, which allowed me to begin investigations on maturity and its relationship to the spine. And it's been incredibly helpful to me ever since. So let's see here. There we go. So this is the study, which is a longitudinal prospective investigation. And we had a group of excellent investigators with me, statistician, anthropologist, endocrinologist, and then two other orthopedists who've been involved with it. And this is based upon our Hibbs Award paper on adolescent spine growth from the SRS. And this is just sort of a brief summary of that, is that we found that children are growing very rapidly during their adolescent growth spurt. The spine is growing at about 2.5 centimeters per year as children are going through that rapid adolescent growth. And it's much higher than is reported from prior studies, which have all been cross-sectionally based. We also found that the spine has much more remaining growth than the rest of the body does. The peak height velocity occurs at 90% of final height. And if you look at the spine growth, this shows percentage of growth remaining. It's sitting around 87%, while the rest of the body is at 90%. So you still have much more spine growth, and it is very rapid from then on. This allowed us to begin calculating multipliers, so that if you take the current height of the spine and you multiply it by the multiplier, it will give you the final height at maturity, which could theoretically then allow us to place tethers or make other predictions about what's happening with spine growth over time. These were our specific aims. In children prior to the adolescent growth spurt, we were going to identify the relationship between chronologic age, percent height attainment, skeletal maturity, and current spine heights with their adult spine height. And then we were going to use predictive modeling to come up with answers to help you identify where things would go in the future for that. This all started out very smoothly. I had a medical student who went between her 3rd and 4th years of medical school, and she started out measuring the spines, doing a lot of maturity measurements. I had a group at the University of Missouri that was looking at the skeletal maturity on these children, and it's using the Fels method, which is an incredibly detailed method. And our statistician began developing a model of childhood growth. Childhood growth is relatively linear compared to what happens during the adolescent growth spurt. So it's a very different pattern and much more predictable. So we made a lot of good early progress with this. We got our data in and scanned. We ended up getting all the subjects identified, selected, getting their radiographs pulled, and doing the skeletal maturity measurements. Began and nearly completed making all of the spine measurements there, and began developing the preliminary statistical model for height using a separate data series from Berkeley, California. Where we got hung up was with the statistical assessment and modeling using more detailed data for spinal growth. And I'm going to take you through a little bit about what happened with some of that. So we started having some strong gales blow about this time, making headway a little bit more challenging. Our statistician, Zuya, had a collaborator on another grant, and there was some ID stolen on this, and she was made the sole investigator on a large grant that she was only a co-PI upon. And this other investigator really threw her under the bus. And so she became responsible for a very large grant that she did not write, and it was potentially ruining her career. She spent about a year in much distress trying to work through this and really put a halt to what she was able to do statistically on our project with this. Our medical student finished up her work in the summer of 2018. She'd made all of her spine measurements. She started out her MS4 year with out-of-town sub-internships. And at this point, we found a discrepancy between Emmons' pelvic predictions of spine height and the measurements that we had. We began diligently trying to resolve all of this. We're working very hard on completing it. And then we experienced some early hurricane force winds. And I accepted a new position at the University of North Carolina, Chapel Hill as chair. I started this role in April of 2019. And as you might expect when starting a new job that has a lot of administrative role, all my research was really put on hold just while trying to get the job started with the goal of getting it back and going again reasonably well. We were making great progress on the department. And then all of a sudden, the Category 5 hurricane set in, and this poor boat began pulling on a lot of water. And that happened in February 2019 when all work stopped because of COVID. Our statistician had to stop everything, teach her children at home. The department demanded my complete attention at that point with all hands on deck. And our communication with the people at the University of Missouri and my collaborators who were both at Case Western and at Yale really stopped as all of us were stuck with all of the challenges facing us from COVID. So fortunately, we have some better weather ahead. The medical student who was working with me is now one of our interns, so she will have some dedicated research time here. I am back to slowly working on the Emmons spine length problem, and hopefully we'll get that resolved, which would explain also why we do not have our adolescent paper published yet. I want to get that resolved. But as you might imagine, my progress is a little slower now with everything else going on than it was prior to that. But we have made some further progress. Our statistician has submitted her growth manuscript looking at the childhood growth. We have published very recently, in fact, this past month, our Peacock velocity versus age manuscript, which was really critical for us understanding what's going on with growth during this time. We've re-engaged our Missouri group on the Fells maturity, and we're slowly re-engaging and carving out time to get the research done. So I'm grateful for the SRS. We do plan on getting it completed, but we've certainly faced some really strong headwinds, and it's still an interesting project, and I'm still looking forward to getting it done. So thank you.
Jim, that's a great presentation and a story of the difficulties that you encounter with research and the ones you expect and particularly the ones you don't expect. You know, your aim number 2 was to develop a model that predicts final spine length. Assuming you do that, how are you going to apply that clinically? What questions and what direction is that going to give you in caring for these kids?
So the first question, Doug, that we're going to have to come back to is, do these spine length predictions work in patients who have spinal deformity? We're going to assume that they do for the time being. And one of our assumptions is that idiopathic scoliosis is essentially a disorder of growth on one side of the spine or on one column of the spine, or however you want to define it three-dimensionally compared to the other. If that is truly the case, then much like we're doing hemiepiphysedesis of the extremities, we would expect to make it predictable what you could do with effective tethering or some form of growth modification of the spine. So I think that becomes one very important aspect, and that we could use hopefully the multipliers to allow us to know When should you tether? At what skeletal maturity stage should you tether? A second issue is dealing with young children and with growth of the spine and what we need for growth of the lungs. If we can predict what their spine growth should be, and then we can begin applying this to, we have a 4-year-old child right now. How are we going, what should their spine length be at maturity? And then start looking at how neuromuscular spines are different than the idiopathic spines compared to normal spines, and then ultimately on the congenital spine. So it's going to have to go through a process as we're trying to figure all of this out.
Great, thank you. Renee, do you have any questions? I mean, it's all speculation right now because we haven't seen any results yet, but do Renee or any of the other presenters have a question for Jim?
I was just looking at the Q&A, but it's still pretty empty. So I'd like to ask you just a very practical question. What do you use, Jim, in your daily practice for maturity assessment? You use hands. I'm convinced that you will use hand.
There might be a good reason for that. And again, thank you for the SRS for funding my research that allowed me to figure that out. So
do you take, what I wanted to know is, at each visit, do you take hand x-rays, or do you look at the wrists, or do you look at the humeral heads? Because you published on that too, I believe.
Yes. So when I use skeletal maturity when I'm trying to make a decision, and I don't need that at every visit. If I have made a decision that I'm going to be bracing a child and treating them with physical therapy for progression of a scoliosis, I don't need to get new maturity measurements every time they come to my clinic, because I know about where they are going to be. So it's really once we're trying to reach a decision point. So am I going to abandon a brace, stop using the brace? Am I going to need to do surgery because this curve has gotten so large? Those are really the deciding factors.
Yeah. So, and then you use always the hand x-rays, or do you look just, from the corner of your eye, do you look at the iliac crest also, or how do you interpret it? How do you interpret the multitude of data that you have? So
the triradiate cartilage on the pelvis to me is a very useful sign. Beyond that, the Risser sign itself is really not that predictive of where the child is. So I've really found that I've had to abandon the Risser if I want to understand what's going on. I'm so used to getting the hand x-rays and reading them that's what I do. It's very facile and moves on very quickly.
I can understand that.
Jim, here's a question from Carol Wise. Can you quickly list the anthropometric measures that will be incorporated into the model?
So there are a number of anthropometric measures, but the ones that we're really working with currently, Carol, we've been looking at radiographic compared to anthropometric measures. So we are using the pelvis, we're using the distance from the symphysis, superior aspect of the symphysis up to S1 because they measured symphyseal height. In the standing position. We have sitting height on all of the children. We have skull-based measurements. So we're able to, they measured from the center of the ear up to the top of the head, and we were able to identify those radiographically up to the top of T1. They measured to the manubrial notch, and so we have heights from that to T1. So those are the basic heights that we have. We have the standing and the sitting height at all of the visits for each of the children, and these were all normal children.
Great. Lorenzo Costa asks, thank you for the presentation. Do you expect this growth model will reflect the maturation of the spine itself?
I strongly suspect so, because what we saw, at least when we looked at the adolescent model, is that it follows a very predictable pattern in adolescence compared to the timing of the peak height velocity. So where they are on that spectrum is clearly a measurement of the spine's maturity.
And here's a question from Jose Miguel Gomez. Is this a skeletal deformity or is it soft tissue imbalance?
Are we talking about, is scoliosis itself?
I think so. I think that's the question.
And again, we're going to speak about idiopathic scoliosis or neuromuscular scoliosis. And it strongly appears that this is a soft tissue abnormality, which eventually affects the bone.
Moyo Crute says, is menarche involved and how is it defined?
So menarche, which occurs at the first menstrual period, always occurs after the peak height velocity. It has about a 1-year standard deviation on when it occurs. It is not a reliable sign of where a child is within their growth, other than being beyond their peak height velocity.
Great. Well, there's no open questions, and I think we're a little bit ahead of time, so we're going to move on. Jim, thanks so much. All right, our next presenter is going to be Dr. Brian Varisco from Cincinnati Children's, and he's going to speak to us on lung microstructure in adolescent idiopathic scoliosis before and after posterior spinal fusion. You're muted still, Dr. Varisco.
Mute. Now you can hear me, I bet.
Yeah.
Is that right?
Perfect.
Sounds good. So thank you so much for the opportunity to present and for the SRS for supporting this work. I'd just like to say to Dr. Sanders, I think we can all commiserate with the pain of the last year with COVID. And it's a, I think it's a good example and point that, success in research isn't really probably determined so much by your intelligence as much as by your perseverance. So I think we should all just keep plugging at it. So lucky for me, we slipped this research in just before the storm. And so I'd like to talk a little bit about what our findings in lung microstructure in adolescents. So I'm actually a pediatric intensivist who has a lung program in developmental lung biology, understanding the transductive mechanisms that are important for lung development. And it turns out that stretch and strain are really important in that. And so I worked with Dr. Sturm and Dr. Woods here at Cincinnati Children's to develop a program that we could answer this question of whether or not changes in thoracic anatomy altered the structure of the lung. So I have no relevant disclosures for this particular presentation. So things that the group may or may not be aware of in general is that alveolarization, so the formation of these thin-walled structures in the lung that are important for gas exchange, that actually continues throughout adolescence. So this actually was controversial for a while. People thought that you basically had your set number of alveoli at about 4 or 5 years of age, and that they just continued to get bigger. And it turns out with some recent studies using hyperpolarized gas imaging that about half of lung growth from that point through mid-adolescence is increase in alveolar size, and about half of it is actually neoalveolarization. So you're continuing to make new lung throughout this period when kids will develop adolescent idiopathic scoliosis. If you change the dynamics of the lung, so if you take a lung out, whether you're a mouse, a rat, or a human, you can actually induce realveolarization. So there was a great New England Journal study about 5 or 6 years ago, a woman who had a pneumonectomy for cancer, and she was like a marathoner, and she decided to keep running. And they noticed on CT, well, it looks like she's just continuing to grow a lung. And so they actually quantified her number of alveoli, and sure enough, she was regrowing new alveoli. They weren't just getting bigger. So as you know, when you have scoliosis, and then when we perform posterior spinal fusion for that, we're changing those dimensions and you're changing dynamics. So there's data that it improves diaphragmatic function, improves respiratory quality of life. The data on pulmonary function tests, as you probably know, isn't that impressive. That it's not clear that when you do a posterior spinal fusion that you improve the pulmonary dynamics. But these other more precise measures, it does seem to make a difference. So what we decided to do is to use this newer technique to actually quantify the lung microstructure. And so how this works is you take hyperpolarized helium. So the way proton MRI works, so you remember from medical school, is that you have a strong magnet that aligns the spin of electrons in hydrogen, so in waters. So about 0.1% of those protons will be aligned, and as they fall back into randomness, they emit electromagnetic radiation, and that's what your MRI is measuring. So you could do this with other particles as well. And so what we do is we use hyperpolarized helium. You can also use xenon. And you use a special optical spin transfer device to get about 30 to 40% polarization of those helium-3 molecules. And then you have a patient take a breath in, and when the patient breathes in, what happens is you can measure with 6 rapid sequential measurements the movement of each of those atoms through the air spaces. So it's going, it's going to diffuse a certain distance, which is the delta x. If you have, it's a very restricted space, it will bounce around and you'll have an apparent diffusion that's very small. Whereas if it's a big open space, you'll have a large amount of diffusion and the space will appear very big. And that is your apparent diffusion coefficient, which is linearly related to your actual mean linear intercept, which is a measure of alveolar size. Additionally, what you can do is you can use some nonlinear modeling methods and watch that diffusion progress as it goes through a lung tube, and you can measure what is the outer diameter of this septated tube, what's the inner diameter, what's the height of those alveoli, and then you're also able to calculate what's your surface volume, your volume to surface area ratio, and other measures. And so what we did is we performed all these measures in scoliosis and control patients, segregating out the right and the left lungs so that we were able to compare convex and concave to each other. So we hypothesized that what we would see is that in scoliosis, we would have a reduced number of normal sized alveoli in that concave lung. So our hypothesis being that those mechanical forces are determinative in alveolar structure. And that after we did spinal fusion, what we would see is that we would have, at 1 year, we would have an increased number of normal sized alveoli in that formerly concave lung. So we enrolled subjects that were recommended for spinal fusion. And then we were recruiting my girl's friends in the community, along with other people as controls. We performed proton and hyperpolarized helium MRI using a 1 liter breath hold. And then we compared right, left, and pre-post, both gross and microstructural changes. So things that we discovered. The first thing we discovered is it's really hard to get older teenage girls to come into the basement of the research building for MRI studies. So the age difference that we were able to get the younger kids, but we weren't able to get the older kids. Particularly, we had several, but not as many as I had wanted. So if you look at the differences between the two groups, the control subjects are younger and they're a little bit shorter, which probably isn't too compared. And we had not great representation of underrepresented minorities, which is a problem that I think everybody struggles with in research, and we all need to be diligent about trying to increase our participation of underrepresented minorities. So the first, I put some selected measurement data here to show you. So up here on the upper left, what you see is the question is there any difference in the surface area to volume ratio? So are the alveoli differing sizes, either between control and AIS subjects or between the right and the left lungs of control and AIS subjects? And what you'll see is the answer is no. So the alveolar size is within a couple of microns in almost all the subjects, both going right to left and between the control and the AIS. The other thing that's notable is there's a fair bit of variability between subjects. So we know that there is about, just in normal adult humans, you can have about a 2-fold difference in the number of alveoli that there is between adults. So that's sort of the noise in the system, is the difference in alveolar size between patients. So then as a more direct measure of alveolar size, we just looked at the concave to the convex lung of scoliosis. And what we found is that there really wasn't much difference in that direct measure of alveolar size. So within several microns, this one patient had a little bit larger, alveolar size of his right lung, but her right lung, not much of a difference. And then these are all just comparisons of all of our different measures, and there is essentially no difference in the septal height and the number of the calculated number of alveoli, alveolar size, surface volume to surface to volume ratio. And then, as you would expect, the right lungs were a little bit bigger in both subjects because the right chest doesn't have a heart in it. And so the lung size is just a little bit bigger, just sort of validating that we were actually able to measure what we, our measurements were accurate. There just wasn't much in the way of difference. Then we took the 1 year. So we chose a 1 year time point for follow-up for a very practical reason, because that's the last time you can reliably expect these scoliosis patients to show up to orthopedics clinic. So at their 1 year clinic visit, we repeated their MRIs and we got as many of the control subjects as we could. We only lost 3 control subjects between the time points. And what you can see is that it's consistent with what was previously published, that over the course of a year, you have a slight increase in alveolar size. And there was no difference in that change in alveolar size between the control and the AIS subjects. So what you have here, the control are the median runs right through here, and this is the 95% confidence interval. And this is the baseline and then the 1 year. And so you can see that the slopes of those line up pretty closely, and that there's not much of a difference in the AIS subjects at baseline or at 1 year. And so, and then it's the same with the convex lung. There really isn't much of a discernible difference. The only change that we were able to measure was that in that concave lung, after spinal fusion, the volume decreased, which is what you would expect. So it was only 40 milliliters that we measured as a difference, but it did decrease, and that the alveolar density went up slightly. So while alveolar size typically increases over the course of time, when you scrunch down that lung, it doesn't increase. You actually were about the same pre and post. So, and that makes sense. So our hypothesis was incorrect. We did not see that alveolar size was maintained, at least at that 1 year time point, that the alveoli that you had were just made a little bit smaller. So this just to conclude, neither scoliosis nor posterior spinal fusion had a substantial impact on alveolar number or distal lung microstructure. You could argue that we didn't have enough subjects, we didn't wait it long enough to see any changes that might occur. We were comparing a slightly younger group to a little bit older group with the scoliosis subjects. You could also say that the way we did the breath hold, we should have done an FRC, sort of a weight or a height-based breath hold instead of using 1 liter for everyone. But regardless, we did the same thing at a year and we didn't see much of a difference. So those are all criticisms, but I think you could also agree with me that there really wasn't a trend to be seen. So I think what we're saying is that if you want lung mechanotransductive induced lung regeneration, really requires a more profound change in lung dynamics than is present in AIS or is induced by posterior spinal fusion for that. So I'd like to thank our funders, Dr. Toman, who performed this, was our sort of point person with the hyperpolarized helium, who moved to Missouri, Jim Quirk, who did the nonlinear modeling, investigators at the Pulmonary Imaging Corps, Orthopedics, and Critical Care Medicine here at Cincinnati Children's. So again, thank you for your time, and I'm happy to take any questions.
Great, thank you, Dr. Varisco. That was excellent. There's a question from Dr. Lee. A very cool MRI technique. How reliably is the correlation between apparent diffusion coefficient and alveolar size? What is the floor and ceiling limits and the dynamic range of the correlation?
Well, we use the same method in mice, so it definitely goes down to at least about 35 or 40 microns. And it's been used in emphysema where people have like millimeter-sized alveoli. So it has a pretty large dynamic range. And as far as reproducibility, if you image the same patient sequentially on each day, you can get within a micron. So it's very sensitive and very reproducible.
Gotcha.
So it's a great technique. And I think it's being used for a lot of to assess a lot of different lung diseases.
Dr. Mehta asks, do you think that a longer follow-up will reveal more useful information?
I'm skeptical because we didn't have a lot of signal on the front end, right? So I would say if you saw differences in scoliosis and control on the front end, then maybe I just need to image them at 5 years or something like that.
Yeah.
But what's your signal? So you have the baseline variability between subjects, and you don't have much of a signal between control and AIS in the first place. So I have a hard time believing you're going to see much of a change, even if I image them 5 years from now.
Yeah. Tom Schlosser asks, in AIS, there are not only changes of the number of alveoli, but also of the airways, narrowing of right-sided airways by spinal intrusion. What do you think is the impact on the size growth of the small bronchi?
So that was am I still sharing? I'm not sure.
You're off. You're off.
Okay.
Yep.
Regardless, so that was the R and the big R and the little r measures. So we were looking at that. I mean, I didn't make that clear, but there really was no difference. So you're able to measure the outer and inner diameter of those conducting airways, and there was no difference.
Gotcha. Dr. Sponseller asks, do you have plans to study natural history of untreated AIS? Can this be used in infant studies?
Yeah, so that's Dr. Sturm's big question. I think he's on here. So it is challenging. So the scanner is in the basement of the research building, and I was unexcited about performing sedation in some neurologically abnormal infants,
right,
with restrictive lung disease.
Yeah.
So as a practical matter, it would be challenging. And then the other challenge, so neuromuscular is the one you're really interested in, that maybe is more interesting, right? Those patients a lot of times have very severe restrictive lung disease.
Right.
So mucus is a big problem. So if you have any sort of mucus in your airways, it's really going to impair the restriction. And you and I know that these patients with severe neuromuscular scoliosis, those are the patients that often get atelectasis from compression of that mainstem bronchi that is causing, it just causes lung collapse. So there's some practical limitations that I'd love to overcome, but kind of having a hard time seeing a way forward with that.
Right. Well, listen, that was outstanding. Thank you so much. There's a few questions left, and those will get answered electronically. We're going to move on to the next speaker. Thank you again, Dr. Varisco.
All right, thank you.
So our next speaker is Dr. Yilgor at Acıbadem University in Istanbul, and he is going to speak to us on the effects of vertebral body tethering on disc and facet joint on AIS patients, and MRI study with minimum 2 years follow-up. Calgar, thank you.
Thank you. So I want to start by thanking SRS for making this research possible, and for Doug and Renee to give us the opportunity to present it. No disclosures relevant to this work. So this is a research on a relatively hot topic, which is the VBT. So as you know, it's a flexible and dynamic system, but as we put the screws and the tether on the convexity, we apply compressive forces there, and the deformity correction is generating destructive forces on the other side, on the concavity, and there's a relative stabilization effect. So there were all these concerns that this may potentially cause degeneration, ankylosing, or spontaneous fusion. Actually, when we look at the literature with the animal models, the result was that tethering is preventing degeneration due to its less rigid nature compared to other growth-friendly techniques. But the animal studies generally are that, we are applying the tethering on a healthy spine to create a deformity, while in the human cases, the tethering is applied on a deformity and corrected. So we thought that the results of these animal studies cannot be directly extrapolated to humans, and that we have a still lack of evidence regarding the effects of VBT on the discs and facet joints. So the aim was to understand and investigate the integrity and health of the discs and facet joints during deformity correction and growth modulation with VBT surgery. So our patient cohort is all thoracoscopically operated thoracic-only VBT patients. And we got all the demographic, perioperative, radiographic, and complications data at pre-op, early post-op, and then at the time of MRI, which is at a minimum of 2 years. And then we kept on getting data for the complications as the patients kept coming in. And we looked for the discs and facet joints by a blinded senior radiologist. So he looked at the intermediate segments as well as the upper and lower adjacent segments twice at an interval of 2 weeks. And then he looked at the pre-op and follow-up MRI images a month apart at random orders. So the intervertebral disc scoring was done according to the Firman classification, where a grade 1 would be normal and 2 to 5 would indicate some kind of degeneration. And then for the facet joint scoring, we made a scale that's adapted from Weishaupt and Park, where 0 is normal, 1 and 2 refer to some kind of stage of degeneration, and then 3 would be a bony fusion of the joint. So what we looked at was the coronal and sagittal measurements, the height changes over time. The most important one is the changes between pre to post-op MRI, and then the SRS-22 scores as outcome measures. So we had 25 consecutive patients in this series, 23 were female, and preoperatively, the mean age was 12, with a mean Sanders of 3 and a Richter of 0, and 74% of the females were premenarchal. So pretty much they were relatively skeletally immature to start with. And then perioperatively, we operated them for 7.7 levels of tethering at a mean. And when we look at the Lanky types, I want to point out one specific detail, because I think it's important for the results, is that we had 5 1AR curves, but we only had 3 long thoracolumbar fusions. So this is because in the beginning of our career, we used to do some smaller tetherings for these patients, but then with experience, we are now doing longer and longer, as we did in the posterior cases. So when we look at the results as the measurements, clinical and radiographic measurements, one can see that in the height of the overall total body height and also the UIV, LIV height, where the operated tether segment, we have seen growing in both. And as we look at the curve magnitudes in the operated thoracic curve and in the non-operated thoracolumbar curve, we have seen some growth modulation occurring over the 2 years. So the follow-up MRI was at a mean of almost 2.5 years post-op, which goes up to 5 years post-op in one case. And at the time of the MRI, 80% of the patients were close to their skeletal maturity, like Sanders 7 or 8, and another 16% was Sanders 5 or 6. And the median reserve was 5 at this point. So we started off with relatively skeletally immature patients, and then ended off with patients that are closer to their skeletal maturity at the end of 2.5 years. So what we have observed was there was a total of 217 levels of discs and bilateral facet joints, and almost 98% and 99% of the discs and facet joints did not show any degenerative findings if you look at each disc and facet joint. But when we look at patient by patient, so on the left-hand side, you see the discs, and on the right-hand side, the facet degeneration. So 23 patients, so these are not the same 23 patients, but 23 patients for the disc and 23 patients for the facet joint did not have any degeneration pre-op and no degeneration at the time of the follow-up in 2.5 years. And there were, in each group, there were 1 patient where there was a preoperative degeneration already, which did not increase to the next stage. But in the pre-op disc, there was 1 patient with multi-level grade 2 degeneration, which deteriorated into grade 3. And then for the facet degeneration, there was this 1 patient, a Lenke 1AR curve, which we tethered a bit short. And it started off with a 0, no degeneration, and then ended up having a new onset lower adjacent facet joint degeneration. So looking at the results, so we know that this is very preliminary at 2 years, but if this red line was the time of MRI, So the overcorrections, most of the overcorrections we have seen was before the MRI. So overcorrection meaning that it was grown longitudinal too much and there was too much angular correction. So the stressors were high for these patients, and the broken tethers were actually after the MRI. So this gives us an impression that, you know, during the time of the MRI, we already had a lot of stressors acting on the spine. So when we look at the PROMs, the self-image, mental health, and subtotal scores have increased. Function and pain were pretty much similar with the pre-op. So in conclusion, the intermediate and adjacent segments, the discs and facet joints, so they were subject to either compression or distraction and also relative stabilization for a mean of 29 months. And there was growth modulation occurring. So we did not show significant degenerative findings for these cohorts, but we definitely need larger patient cohorts and longer follow-up to know more about what's going on in the discs and facet joints after VBT. Thank you.
Thank you very much. That was outstanding. The first question from the audience, did disc height remain the same, and any data on dynamics of the discs years after VBT?
So I think this is a great question. So now we are doing the next phase of the study and incorporating it with also, you know, doing some morphological measurements. So in this study, we didn't do any morphological measurements. So we didn't check for the height, but we only checked for the Firman classification.
Gotcha. From Per Trobrish, do you believe that the amount of intraoperative correction, that is more correction equals more tension required, has a negative effect on disc health or height?
So this is also, I think, something that has to be checked in the future work, because, you know, what we really didn't know is about, you know, how much correction we did in the surgery. And also, I think that's also correlates with how much flexibility the patient had. Because in some cases, you know, we did really a good correction without too much tensioning. And on the other case, it was the other way around.
Right.
But pretty much in these patients, these are like the first 25 patients that we did. So actually, you know, on those days, we were all doing pretty much the same thing. We were trying to aim for the same intraoperative correction. And so I think they had quite similar techniques in how we have corrected them.
Gotcha. Did the two patients with imaged evidence of disc facet degeneration have pain that is localizable to the degenerative area? Were they symptomatic, the two that showed degeneration?
No, actually, I think it was also pretty interesting finding to find that, you know, there was patients that had already pre-op degeneration, and some was like grade 4 Firman and someone 2. And on the other side, and the facet as well. And even the ones that had preoperatively were not really symptomatic. And the ones that got degeneration during the course of the study were not significantly symptomatic.
Gotcha. And this question from Dr. Mehta, can you comment on the effects of the discs and facets based on the lumbar lordosis restored?
Well, in this study, and in also other VBT studies that we have done, what we have seen in the thoracic kyphosis and lumbar lordosis was that, you know, there was a slight decrease postoperatively, and then it's in the longer run, it came back to what it was in the pre-op. So we can say in general that the sagittal plane was not altered significantly for these cases. So no comments on, you know, how it would affect the degeneration or not having degeneration.
Right. Here's a question from Dr. Resko, and I'm assuming he just said ROM, and so I think he's asking, did you measure range of motion? Is there any kind of range of motion measurements associated with your study?
So there were only like 2 cases in this series that we have went on to do some posterior fusion. So on those 2 cases, we had the preoperative bending images, and then we have our intraoperative, you know, the feeling that we had, and they were still quite flexible in the images and also intraoperatively. But for the other patients, we haven't done any radiographic or clinical assessment of the flexibility that they have.
Okay, great. And from Dr. Croy, how can you explain there is no difference in assessment results between the tethered segment and the untethered segment? I'm assuming in terms of degeneration.
So actually, we only looked at the one level below and one level higher. So because these were like thoracic MRIs, we didn't do MRIs for the thoracic and lumbar. So we don't have too much information on all the other segments that were not tethered. But we only looked at the ones that are within the tether, one above and one below. And they were pretty much, showing similar patterns.
Gotcha. From Dr. Gomez, again, any idea how to score the remaining flexibility factor? Not sure I understand that.
So I don't know, maybe like, the Philadelphia team is working on some clinical, imaging, like, studies on flexibilities, or if it wasn't, the radiation exposure, we could have done some, bending X-rays, but maybe, it would be more relevant after maybe 5 years, because at 2 years, actually, I think we didn't expect too many degenerations anyways. So
right. They're still pretty young. Dr. Resko, again, was there any specific characteristics of the disc when it was at a broken tether level? Was that different than if the tether was intact?
So we only had one patient which had a broken tether at the time of the MRI, and that was not one of the patients that were degenerated. So we don't have too much to say about how you could expect the things to change once the tether is broken.
Okay. All right. I think this will be the last question. Is connective tissue issues such as joint hypermobility being identified within this set?
So we tried to keep it all AIS. So we have operated some other causes that have scoliosis as well, but they are not included in this series. So I think also this would go for some future research.
Yeah, there's a lot more to study, right? We're going to end there. Dr. Yogor, thank you so much. That was excellent. And again, I want to thank all of our presenters today. On behalf of Professor Castellane and the SRS leadership, I want to thank our presenters and all of you who have participated and taken the time this morning, afternoon, or evening, depending on your continent, in our first ever research grant outcome symposium. And in particular, I want to thank Laura Pizer and the SRS staff. We all know that without them, this program would not have been possible. As we like to say in the SRS, research is our middle name, and you can see that our investment in research is supporting a wide variety of topics and investigations that we think will help us better care for our patients with spinal deformities. And as Virginie told you earlier, over the past 7 years, we've had 75 grants awarded to investigators in 9 countries across 3 continents, totaling over $2 million, resulting in 122 presentations worldwide and over 60 publications. But we believe that we can and should do more. And this next year, if you total up the grants that Virginie went over, we'll be awarding upwards of $450,000 in grant support. And this includes our new directed research grant. And this is going to be new coming on next year. And this will be a specific topic, and it will be a 3-year, upwards of $300,000 over the 3-year award. And the topics are going to be chosen, the topic will be chosen through a collaborative process that will include our SRS membership, various stakeholders, and then ultimately approval will be given by our board of directors. This is underway, and this effort is nearing its end. We've chosen our top 15 topics, And these have been sent out to the leadership within the Research Council for final selection. And we will be presenting our recommendation for a directed research topic to the board next month. And we hope to have a request for proposals go out to the spine community this summer. This concludes our program. I would ask that the audience please participate in the survey that will launch at the close of the meeting. We want your feedback to improve this program for next year. Thanks to all of you, and have a great rest of your weekend.